Thank you, Claudine. That was fantastic. Claudine texted me about an hour and a half ago and said, I'm putting your quote in there and letting people know. So it is what it is. I also didn't know about the 700 pills, but that's another story for another day. That's not what I meant to share. Sorry. Thank you again. And I'm just going to finish things off with a very short presentation. I know we're tight on time, so I definitely want to be sure that we're not going to extend ourselves too much. And we have an excellent closing ceremony that we want to get to. Again, some minor conflicts. I did some consulting. I was at advisory boards for Tilray and Canopy after getting a CIHR grant for cannabis research. Otherwise, in the last few years, I've not done anything else. I have a lot of jobs. The only people who care are my wife and kids. So I thought we would start by talking a bit about pain and the epidemiology of chronic pain. First of all, we know it affects approximately 20% of the population. It doesn't matter if you're in Australia or if you're in Europe. There was a question on one of the chat boxes of, does anybody know Australia? Well, it's about 20%, 18.5%. It's about the same everywhere. And in Alberta, that would represent approximately 800,000 people who live with persistent and chronic pain. And they do not all go for treatment at the same time. It would certainly overwhelm our entire system. And we have to try to figure out why some people do and why some people don't. And if this conference didn't help with a lot of that, I don't know how we can help. So let's talk about policy. What can we do? So we're going to talk a bit about the addiction response. So we can take a look at what we've done for addiction, and maybe we can try to mirror that and also look at some of the gaps that we have. Now, we have supervised consumption sites in most of our major cities here in Alberta. When we look at these supervised consumption sites, we're actually publishing, Tyler Marshall being the lead author, a paper showing the more a supervised consumption site works, the less overdoses you see in a population. This will be the first population study showing the benefits. The problem is trying to get people to use the SCSs more often, which is really an issue that we've had. In Alberta, we have a network of opioid dependency programs. These are programs that provide Suboxone, Methadone, Kadian, and other opioid treatments. And we can see the numbers continue to grow. We're the only province with a full network that supports the entire province with publicly funded opioid treatment programs. We can see methadone. We've seen minor increases in methadone, but there's been a ton of education on buprenorphine naloxone, and we've seen this significant increase in the prescribing of buprenorphine naloxone over the last several years in the midst of this opioid crisis, or what I should say is an overdose and illicit fentanyl crisis now. And of course, naloxone, probably the most effective harm reduction tool or preventing of death tool that we simply have in our arsenal. It works. Sometimes we have to use more, sometimes not as much. And certainly the most important thing we can do, as of March 2019, this is old and I couldn't get a new one, 145,000 naloxone kits in Alberta. There's no cost, there's no prescription. You can get it anywhere. Carry it with you. I have an intranasal and an injection one in my bag at all times. And I have flown all over the world with that, and not once have I ever been questioned about it. We want to look at some innovation that we have done here in Alberta. Of course, our supervised consumption services are extremely important. Our opioid dependency program, as well as our deprescribing program, which you heard a little bit about, also extremely important. We have a community rapid access addiction medicine program. This is the first true community program not affiliated with any specific hospital, because addiction is treated in the community, not in a hospital. Our virtual opioid dependency program. You can literally get support for opioid use disorder in Alberta anywhere you live just by picking up the phone and getting that help. And all physicians in Alberta have that support if they need to prescribe it. We have a severe mental health and addiction program called the Addiction Center that really focuses on those with bipolar, schizophrenia, severe and persistent mental health. We have an emergency department Suboxone protocol. Any person wanting help can simply walk into an emergency department and urgent care anywhere in the province, and they will be prescribed buprenorphine naloxone when they show up. We have an incredible ARCH clinic, or the Addiction Recovery and Community Health Clinic, that supports people in hospital, and our hospital consultation programs throughout the rest of the province, supporting those with addiction while they're in hospital. We have a new process of therapeutic communities. These will be communities that someone can go for residential inpatient treatment for at least 1 year, not 18 days or 2 weeks or something that you can't stop chewing your nails in that time. We have injectable hydromorphone medication, or IO clinics, that there's a lot of politics there, but certainly something that's absolutely necessary, makes a huge difference in lives, with over 80% retention to treatment. And really, the plan is to work towards on-demand, immediate access treatment for everyone and anyone with addiction, including, as mentioned, our virtual ODP. This is a bit about our buprenorphine naloxone. We've seen more and more uptake in this in the emergency departments and urgent care centers. But right now, if you're a patient with addiction in Alberta, this is what the map looks like. You show up somewhere, you're referred somewhere, and you hope you get there. And we have no idea how many people fall through the cracks. Nothing is interconnected. Nothing is working together. And it's just about really personalized connections. And there's some real work that we have to do to separate that all out and create it in a form of a hub and spoke, where we have some sort of centralized clinic that can support everyone. And we have referral sources all over the place, from harm reduction to primary care to emergency departments, and a continuum of care moving forward in a case management process to make sure we don't lose patients on the way. But what about pain? How does that support people in pain? Well, we do have our Alberta pain strategy. And what we needed to do is figure out, what do we have? I can list off all the addiction stuff, but what do we have in pain? And so a lot of what we had to do was an environmental scan. And in the midst, we're looking at models of care and outcome measures to understand what we're doing and how we're doing it. We had some low-hanging fruit policy, perioperative pain management and medication policies. Excuse me. Education, a repository for patients and practitioners. Really, people with pain should have access to this. Of course, I get a coughing fit now. And of course, clinical, moving into transitional pain. Then we have research. Things that we can move into immediately is focusing on research, and something that we're doing right now. This was all presented on Friday. But what about a hub and spoke for pain? And what would that look like? A classic hub and spoke looks something like this. You have the hub in the middle, spokes all around. The hub is usually a tertiary pain program, and the spokes are some sort of primary care program. What we'd like to see is a slight modification to that would be a tiered hub and spoke. The hub is that tertiary pain program. The spoke is a primary pain, or a primary care network pain program, for each of our zones having separate primary care areas, with each of them having their own pain programs, and then specifically down to the primary care team itself. So eventually we'd like to see something like this, where we have a central hub that's connected to another central hub with several PCN clinics and primary care networks all intermixed through there. The primary care initial spoke will focus on education, physiotherapy, and group pain programming. And for those that are struggling to continue further, we can move into a primary care network pain program. And we have some experts here on our committees, and from what you've heard from, can include things like perioperative and transitional pain, physiotherapy, kinesiology, mental health, addiction, medical management, and interventions. And interventional treatment is something we haven't talked about much at this conference, but is certainly evidence-based and helps turn the pain generator down so we can focus on so much more of pain. And finally, our tertiary hub that can include things such as neuromodulation and trauma therapy and intense outpatient programming. Really the best of the best, with the most experimental and up-to-date treatments available to everyone and anyone. None of that really exists right now in Alberta. And in fact, we have some great PCN clinics here and there. We have some amazing primary care practitioners that are excellent at treating pain, but we really need to work on turning it into a provincial platform that makes sense for everyone. Now, the one thing we don't talk about a lot is mental health. And some of the important things that we want to focus on is how do we empower people? How do we help people not perpetuate disability? Using words like pacing instead of earned pain is something that can sometimes drive some people nuts, but feeling okay to go skiing for a couple of hours instead of a full day, feeling okay to wrestle with your kids and knowing I'm going to hurt later, but it was worth every second that I did it, challenging yourself as you're doing it, using your mind to change the brain, to change the mind, to change the pain, value-based acceptance therapies, and yes, you can. But we do have to focus on what the DSM has to say, because a lot of those things that we're trying to do can get interfered with by mental health disorders, things like anxiety, depression, and trauma. Now, of course, access to therapy is very difficult. Access to therapy, if you're a healthcare provider, access to therapy, if you're someone living with pain, can be very difficult to get to. And this is where I always encourage people, and I get this question all the time: how do I send my patient to something like this? Well, you could send your patient, or you could learn it yourself and work with your patient to learn it together. And it's really not that hard. We can start with learning how to do cognitive therapy. Judith Beck's Basics and Beyonds is exactly how I learned to do CBT during my residency. And I literally followed it session by session. And every single person I was doing with knew I was using a textbook to go through the process. And that's the reality. It's doing it with someone, not to someone. And of course, there's mindfulness-based programs that, are on retreats, and you can travel all over the world to learn different programs and different retreats, or you can sit at home on a virtual platform in the current issues that we're having today. But I encourage you, at least learn one technique that can make a difference, whether it's mindfulness-based cognitive therapy or just simply mindfulness or cognitive therapy or group programs. Anyone and everyone can do it. In our program, we had a kinesiologist running our mindfulness program, and she was amazing. It's all about taking the time to learn one more skill. But when it comes to PTSD, things get a little bit difficult. We can treat anxiety and depression often with cognitive therapy or mindfulness or some other treatments, but PTSD can be hard to diagnose. Sometimes it's like figuring out a Rubik's Cube. But those who are really good at it, suddenly that Rubik's Cube becomes nothing. And once we learn how to screen for it, you can use the PCL5, which is a screener for PTSD. And once we learn how to treat it, there's some medications that can help, but we got to remember, medications are just part of the process. They're an adjunct to therapy. The treatment for trauma is gold standard is exposure therapy, but there's some other therapies that are out there. But what we need to realize right now is that trauma is treatable. And too many times I hear about informed care, or not triggering people, or making sure we don't upset someone, when the reality should be, why don't we treat it? We need to treat what is treatable. And trauma interferes with everything. It interferes with pain. It interferes with fatigue. It's up to 2 to 3 times more prevalent in people with widespread pain. And if we don't treat the trauma, how can we actually understand how to treat the pain? And the prevalence is there, and it's been studied over and over. And we've heard themes of trauma for the last 3 days. And the reality is now we just have to figure out how to get people the support and help. And that means extending and expanding our knowledge and our availability to trauma-based therapists. And it's not that hard to learn it either. So we just need more and more people doing it. Now, we've heard a lot about opioids. We've heard about the addiction part. What about the treatment part? First of all, opioids are beneficial for some people. Let's not cut anything out of that. That's a fact. Certainly for acute pain, they are extremely beneficial. And hearing some of the horrific stories to our minorities and those of color and our children not getting access to appropriate and evidence-based pain treatment for acute pain is unbelievable and unacceptable. But for some people, we may have gone overboard and prescribed a lot of people a lot of medications. And one of the things that we've learned is getting off of these medications is really, really hard. Now, I want to make sure this is deprescribing. This is not tapering. This is not forced tapering. This is not detox. This is a slow and steady process. And as mentioned earlier, there's evidence for it, even if it's mild. The numbers in that study or in that systematic review were large, and some of those studies were considered not bad, but the overall evidence was very minimal to suggest that it would be beneficial for people to taper. But if we looked at those 8 studies that had some benefit, every single person in those studies, or every one of those studies, showed either no difference in the taper or people significantly improved. So often what I tell people, what do you have to lose, as you heard before? And the worst thing that can happen for most people is nothing. But again, it's an individualized, step-by-step process that we work with people, and we help people who want to do this. And there is a conundrum. And I think that the first time I met Stefan, this was the first study we talked about. Why did you have that up there? And it's quite simple, because it's not a conundrum. The answer is simple. If somebody wants to try to get off, it should be our job to know how to do that. And right now, that is not the case. Now, we know that there's evidence for multidisciplinary care for opioid use reduction, but this was a fascinating review that blew my mind and suggested approximately 60 to 80% of people who undergo multidisciplinary and supportive opioid taper programs remain off of opioids 1 year later. And that was determined to be dangerous. I struggle to understand that. We know that if we force taper and we create discontinuation, tapering, detoxing, that the risk of death goes up. And we heard that from Stefan earlier. There is no question about it. We do not force taper. We do not rapid taper. We do not do things to people. And we have to remember, and this original study here that we were talking about, that I don't quite understand the answer to it, also said not one of these multidisciplinary programs assessed for addiction or looked at addiction. And we saw about a 20% death rate. Well, how do we not look for addiction when there's a Venn diagram? Now, that doesn't mean that everybody with addiction has pain, and it doesn't mean that everybody with pain has addiction, but there are some people that overlap, and we have to be passionately helping those people as well. If we look at the POINT study, which is probably the most effective study looking at and assessing people with chronic pain on chronic opioid therapy for opioid use disorder. Now, they said about 20%, but that included mild and moderate. If you look at severe, it's about 5%. If you look at the studies where we see forced taper, the death rate to overdose is about 5%. So it seems pretty obvious that what we should do is any sort of multidisciplinary pain program should include addiction services and support for anybody who happens to have that comorbidity. No different than it should include support for people who have depression, who have trauma, or any other point that may interfere with their treatment of pain. So treating chronic pain, often with addiction, we look at going to buprenorphine, naloxone, or Suboxone. We've heard it works. Does it work? Well, it was designed as a medication for cancer pain, and the studies were very good in the 70s, showing it was quite beneficial in treating pain in those with cancer. Jonathan Dach did a couple of great studies. The first one had a low power for those over 400 milligrams of opioid equivalencies or morphine equivalencies. But we can see a decrease in pain scores averaging approximately 2. So if you were 7 out of 10, you drop down to 5 out of 10 by that. And it wasn't just a rotational effect. They reviewed for that as well. When looking at the higher dose, he redid the study looking at just high dose, those above 200. And you could see significant reduction in pain scores when individuals were removed from the high dose full opioid agonist to sublingual buprenorphine. And I hear all the time, should we taper them first? No. I've rotated people on thousands of milligrams of morphine equivalents over to buprenorphine, and they've done well. We have no need to taper people if not needed. And if you want to know how to do it, we published this not long ago, and Dr. Clark presented this earlier. Check out the Canadian Journal of Pain. This is an open access study, and basically it's a case report, but it's got clinical pathways of exactly how to initiate buprenorphine naloxone for individuals who have chronic pain and who are on prescription opioids. And now we heard a lot that, you know, should we taper people off of opioids? And there's just one simple answer: if they want to. Because again, as Stefan clearly stated, we should have that opportunity available to people. And when people want to try to come off, they should. And we've got lots of, and we're in the midst of doing a 1-year follow-up to actually publish something. But we have lots of anecdotal, and the current data looks very good, that the outcomes are excellent when done right, when providing trauma therapy, when identifying those with addiction and treating them appropriately, when adding in significant skill sets. So you have that picture of that garage and not an empty toolbox. We can do this correctly. And I had a patient that sent in a letter a while ago and said that I was allowed to use it when I presented. And I don't know if she's here or not, but I want to read this to you. Yesterday, my husband came home with a beautiful bouquet of flowers for me. I feel I have you to thank for this. It has been 4 months since my last injection of morphine. And this was a chronic pain patient that wasn't able to take oral opioids due to a lot of nausea and GI problems. The biggest change for me is, rather than dreading waking up each day to spend hours too sick to leave my bathroom, I now wake up every morning looking forward to what the day will bring. I am doing things I haven't done in 20 years. I am enjoying every moment of it. More than half my days are pain-free, something I couldn't have imagined a year ago. The days that I do have pain, I feel so much more equipped to handle it. You kind of heard that before. The tools that both you and Michelle, who's our psychologist, gave to me have changed my life. I continue to use them daily. Thank you, thank you, thank you. Thank you for your kindness. Thank you for your patience. There wasn't really any need for the patience. I know I was not an easy patient. She was an extremely excellent patient. I know I was more skeptical than most. There was some truth there, very skeptical, but so are so many. I am so grateful for the time you took to answer my endless questions. Thank you for treating me with respect and not judging my choices. Thank you for helping me get my life back. I mean, this is why I do what I do, is to hear the presentation that you just heard. But at the end of the day, what we need to do is individualize every approach we take, because every single person is different. And we need to make sure that our large tertiary pain clinics, all the way down to our walk-in clinics, treat everyone as an individual with respect and non-judgmental. We should never hear the stories that we heard from Tracy. We should never hear of someone suffering in the emerge. We should never hear of hostile environments that traumatize people. We have a broken system, and together we can change all of that.